Right. So today's tutorial, it's all yours basically. We're going to go through some little admin bits that we need to make sure we're up to date with, and we need to make sure that everything's in line and the way it should be. So you should hopefully now see the tutorial main page. Can you all see that, guys? Give me a little nod. Kaylee saying no. Can you see it? It says, are we recording yet? Have you taken the register? Can you see that? Yeah, I've got a couple of nods. Anyone not see it? That's probably easier. Super. I'll take the silence as a good thing. Right, so final tutorial. So today we're going to go through feedback. Make sure you're all happy with where you find your feedback, how to action feedback. Head Start Plus. We should have all completed that now. I don't think there's many of you that haven't. I'll just double check. Just a few of you that still haven't done the Head Start program, but just make sure that gets completed and the certificate gets uploaded. We're going to talk about cramming and panic evidence and how to avoid it. We're going to look at the milestones, make sure we're all happy with our progress on those. Preparation for submission. So what you need to do ahead of submission. We're going to talk about the submission dates as well. Unit 1, overview and advice, which is not pertinent to you guys, but submission deadline. So as Irina said, your submission deadline is officially the 14th of March. However, those that are, you should have got an email from me on Friday, those of you that are shortlisted for the paramedic course, you do need to get your submissions in by the 28th of February. If they're not in by the 28th of February, you won't be able to join that next paramedic program. The reason being is because we need an absolute minimum, ideally 8 weeks, but a minimum of 4 weeks to get your portfolio marching through the IQA process. Until it goes through the IQA process, it doesn't pass. Okay, so in order to get through that process ahead, we've had to bring your submission deadline back so that we can get that process done. In order to get that process done, you have to meet that deadline. All right, guys, that's not a milestone where we can discuss either way. This is a summative submission deadline. So if you are on that shortlisted for that para course, please, please, please make sure your submission is in by the 28th of February. I know there's a few of you, and like I said, I've sent an email out on Friday to those that it was relevant to. If it's not relevant to you and you're not on that, then your submission deadline is the 14th of March. You can crack on to 14th of March. And again, that is your summative submission date. So that's not a negotiation like milestones. That is a summative submission date. All right. Any requests for extensions for any reasons need to come earlier than the submission deadline. So please don't leave it till the last week. If you need an extension, then please just email me and Nick Carter. Email me in the first instance and I'll tell you what you need to produce in order to ask for an extension. And then we'll go through the process if and when you need it. That has to be agreed by SCAS as well. So it's not just something that the university can agree, that has to be agreed by SCAS. Okay. Everybody happy with your submissions and when we're submitting? Super. So cramming. So we see this a lot. I've started seeing it already, which makes me a bit nervous. It's when you start trying to claim things that you haven't actually submitted. So you're writing up a lovely piece of evidence and then you'll sneak in little units that you haven't evidenced, and you've not explained the what, the how and the why, and they've just kind of been tapped in and piggybacked off your work. You can't do that. If you haven't evidenced it with your what, how and why, you can't claim it. Okay. If it's things that are really difficult to achieve in practice, so things that normally come up, although you guys down south seem to end up with quite a few of these, is things like paediatric arrests, severe burns, things like that. And there's obviously ways around how to achieve those without having a direct observation. So how would you achieve that, guys? Oh, Aaron, your mic's not working again, my lovely. Put it in the chat. Professional discussion, excellent. And how can we evidence a professional discussion, Louise? Hi, Emma. Good. So write it up or record it. Absolutely. So professional discussions are quite tricky to transcribe because it's a fluid language, isn't it? So you'll get the ums and the ahs like we do in normal language. So recording it's a really good one. So a dictaphone or videoing it is also a really good one. Remembering what you need to have for video evidence. So you have to have permission, you have to have consent, have to be recorded. To just make sure that all that is on there as well. Okay. Good, Aaron. Yeah, Q&A is another brilliant one, especially for things like burns and wounds. Don't forget on that unit, there is bold writing underneath for the things you have to cover. Treat them like bullet points. All right. So if there's a list of 6 bold words, treat them like a bullet point. Everybody happy with that? Yeah, good. So your portfolio, by the time of submission, should be 100%. Now, I'm just going to show you where you can find that information from, because some of you may not be aware. So if you go on this little eye on the far right-hand side, you'll have a list of things across here, okay? You've got progress, and on progress, it tells you how much of your percentage is complete, all right? On completion, so submission date, 28th of February or 12th of March, I think I said, didn't I? Then it's make sure that's 100%. Okay, if it's not 100%, it's not complete. If it's not complete, you're not met the deadline. All right, make sense? Good. Down here as well, you can also see what your progress is with your units. So you can see where you've done, where you haven't done, what bits are left to do. So if you're not sure why it's not 100% complete and you think you've done everything, this will give you a really good idea of what's missing. So it may be things like your gap assessments you haven't finished, which I don't think any of you are in that position. Your theoretical logbook, you may not have ticked everything. And the summary, we'll have a chat about that in a little while. All right, so all that is available in there for you to look at. So just make sure it's 100% complete. Make sure there's 2 pieces of evidence for each assessment criteria. Now, a few of you have been emailing me to say they're complete, which is great because I need to know, but they're not complete. You've missed evidence, like you've only produced 1 piece of evidence, or you haven't put any evidence in one of the elements. So just make sure that you've got 2 pieces of evidence for every single element that you've got. All right, there's not a single unit that doesn't need 2 pieces of evidence. And then your declaration of achievement and summary. So this needs to be ticked, and so does your tutorial uploads, and your witness details need to be correct and in full information. So when we go through these, it'll all be in here. So make sure you're up to date with your practical logbook. By now you should be hitting a 90% completion, 80% minimum. So if you know you're behind and we're aware you're behind of why, that's great. If I'm not aware of why you're behind, please let me know why you haven't quite hit that 80-90% yet, just so that I'm aware as we approach submission deadline. All right. Your practical logbook, sorry, your RPAL logbook, this should all be ticked and done. And your RPAL evidence should now all be complete. So the only thing that you may not have added yet, but you should be ready to upload now, is your clinical hours, so your 375 clinical hours. Is everybody happy with how we achieve those 375 and what needs to be there? Yeah? Anyone not sure? Because now's a good time to say. Yeah, sure. So you can either complete the document that I sent out, which is basically a Word document that you fill in, so you get it signed and dated, and the clinician to write their details in, and that just gets uploaded into the 375 evidence. Or you can get a GRS printout, and then your team leader has to sign, to say how many of those are clinical hours. So your clinical hours count as a qualified level 4 clinician, so an AAP or a paramedic. And there has to be 375 of those. So that needs to be a signature from a manager to say how many of your GRS hours are clinical. All right. Cool. So then once you've done your RPAL evidence, just make sure you go through these. A lot of you, I think in fact all of you, have ticked these off, but just double check that they are all ticked off. Your gap assessments, they should all now be completed, and you would have had an email from me to confirm. Theoretical logbook, that is your boxes to confirm what you've learned in your gap assessments, and again they should all be completed, done, dusted, no dramas. And then your summary. So the last little bits of the summary that you may have noticed I've started ticking off is under Q&A. I've started ticking off which ones you've completed, or which ones, sorry, I've assessed as completed. All right, so you may notice if you look in there, a few of them are ticked off, and they're the ones that I've signed off. Okay. Once that's been signed off by me and you've submitted your portfolio, you can keep an eye on the progress of the IQA by coming in and looking at if the IQA has ticked that off. So do you remember us discussing the IQA process? Yeah, good. And then once they're all ticked off, your portfolio is good. All right. It will then go to an EQA, which bears no weighting on whether your submission is completed or not. The EQA just keeps an eye on the IQA. So we've got me, an IQA, internal quality assurance. So that's normally Martin. And then an EQA is someone from outside of Cumbria that then checks that Martin's IQA'd it properly and that Martin's IQA'd me properly. All right. So you haven't got to worry about this last box being ticked, but this is the progress of your IQA. All right. Then you've got declaration of submission. So these things need to be ticked off to confirm that they're your work and that you're happy that you've submitted it. All right. So today, whilst you're on the, I'm going to give you half an hour to do your admin. Go through these and tick off which ones you're happy you've done. Okay. Now, if you notice, these go in chronological order 1 to 23, which obviously your practical logbook doesn't go in chronological order 1 to 23. You've got gaps missing. So things like number 1 are covered in RPEL, okay? And other ones, things like the conflict resolution, are covered in your gap assessments, okay? So just bear in mind, no, it's not covered in your gap assessments, but probably covered in your RPEL. Yeah, there it is, conflict resolution. So bear in mind, just because it's not in your practical logbook doesn't mean you haven't covered it. It would have come up in your RPEL or it would have come up in your theory logbook. So make your way through that and make sure you tick off everything you're happy that you've done. And then your course tutorials. So after today's session, Amy will be sending out, not necessarily today, but Amy will be sending out emails to you guys to confirm your attendance. And then that email just gets uploaded as evidence into this area. All right. Steve, you got a question?
Yeah, sorry, you were just saying about sort of the last page where we have to tick everything off.
Mm-hmm.
If we wait till you've assessed that before we tick that off, or if we've submitted it, are you happy for us to tick it off?
It's, yeah, once you've submitted, it's your declaration to say that the work you've done is your work and that you're happy you've completed it. All right, so that's for you. The assessor's page is for me to say you've completed it.
Okay,
all right.
Thank you.
Expert witness details. Now, I'll give you a heads up. This is what IQA normally fails people on. Okay, so again, in your admin time today, make sure that everybody who has signed your evidence is in this expert witness details, because if they're not, you will not pass IQA. All right, so make sure, I said it early and I'll say it again, every time someone signs it, make sure it goes in here, because you don't want to be chasing your tail on that one. All right, so make sure as you go through, everybody is in that list. And then the last one you haven't got to worry about, it's just the milestone page that we give you the feedback on. And then that should all be up to scratch with where we are. If anyone's got to level month 4, sorry, and they haven't got a feedback from me and they haven't had an agreed extension on that milestone, let me know. All right. And then also exactly the same for level 4. So go through your level 4 portfolio in the summary, and there'll be a similar sort of thing as well. Hi, Aaron. So no, it's not compulsory, but it does have to have a numbering of some sort. So it doesn't necessarily have to be an HCPC number, but it does need to be a staff number. So someone's number has to be in there. So the ESR number, so whatever your numbers begin with, ours are 208 or 107, depending on how long you've been around. Yeah, Kaylee?
Hiya, just to go back to the course tutorials, it's on the, I don't think we went through the second one. Is that something, the submission tutorial, is that something that we need to do?
No, submission tutorial is this one.
Yeah, so what do we need to add in there? So we went through the initial course tutorial.
So Amy will email you to confirm that you're attended today, and then you just upload the email as evidence.
Into the submission tutorial?
Yeah, where it says add,
yeah,
just like you would a piece of evidence.
And then the initial course tutorial, what do we do with that one?
Same again, an email from Amy to
upload
the email from Amy.
Emails.
They'll probably be the same email, to be fair, so they just need to be uploaded in each one.
And another question, just on the videos that we're doing, or we can do as evidence, does the paramedic or the assessor need to be within that video, or can we take the video and then a paramedic or an AAP looks at it and signs it off?
Absolutely, that is absolutely fine. So you can produce a video, show it to a clinician, and they can sign it off.
Okay, perfect. Thank you.
And all the details on that are in your evidence guidance on your introduction page. So if you look on your introduction page, there is a FAQ, and in the FAQ there is examples of different types of evidence. On there, it will tell you exactly what you can use for video.
Perfect.
All right. Any questions on that portfolio bit? No? Super. Swimming through. So we'll have a chat about that afterwards. So what we'll do now is we'll give you half an hour, so till 10 to 11, to make sure that all those things are up to scratch and that they're all good. If you are confident that they're all up to scratch and they're good, make sure your level 4 is the same. Okay. And then I'll see you back here at 10 to 11. Any problems, just come find me. I'll still be sat here. So turn your cameras off, turn your mics off. But if you need anything, let me know. And yeah, see you at 10 to 11. Bring questions if you've got anything or you found something, an anomaly that you're not sure of. Just make sure all that admin's up to scratch. Kaylee, is that a new question or is that from before? You there, Kaylee?
Yeah, sorry, my computer is so slow today. Oh no, that wasn't a new question, sorry.
Cool. All right then, guys. So 10 to 11, come back, make sure everything's in order, your admin's all up to scratch, and I will see you then. See you in a bit.
Heidi?
Yep.
My Pebble Pad won't let me log in whilst I'm logged into my SCAS account for some reason.
Yeah, because it comes under your student account.
Yeah, it's always been the same. I can't log in whilst I'm on my SCAS account on
Teams. On Teams, is that what you mean?
Yeah, yeah.
Cool. If you sign off of here and then log back in at 10 to.
Oh my God. Okay, if you don't see me again, then something's gone horribly wrong.
I'll email you the link now to this so you can just get straight back in. All right.
Cheers, thanks.
No worries.
You're right, Stephen.
Yeah, so it's just, you've said to submit everything. I've gone through level 3 and everything that I need is there. I'm just waiting on a couple of ESR numbers. Did you say to go through on level 4? Because I can't see anything else to tick on level 4.
Just go through your summary and make sure your summary is all up to date. So everything, just make sure that everything that's been signed off and submitted is ticked. Make sure that your certificates are all uploaded, that you're happy that everything that you've done so far is on there.
Okie dokie. And the only other question I had is on level 4, on the intro, it says student material upload. Do we have to put anything in there?
You don't have to. No, that was just for people who needed to upload something to support them and they didn't have anywhere to upload it. So like if they wanted to produce a piece of evidence that included, I don't know, appendix for SCAS guidelines or something like that, then they uploaded it into there.
Perfect. Okay, thank you very much.
No worries.
Excuse Heidi, are you there?
Sorry, Rayon, I went to use facilities. You all right?
All right. Yeah, I was just trying to get a question from you in terms of tutorial the evidence. My initial tutorial I didn't get the link sent to me. But Martin did send it to me. So how do I obviously how do we import that to PebblePad? Do we just get a picture or something? Because it
For
wouldn't
your
let me share.
tutorial,
Yeah.
for tutorial, Amy will send you an email to confirm that you attended, and then you just upload that in there.
Yeah, but the email, like obviously, I can't see how I get that onto PebblePad.
Oh, you just take a screenshot, like you would take a screenshot.
Yeah, that's what I was asking. Okay, because I haven't seen any emails from my initial tutorials.
No, Amy will send them all at once. She'll send them in one email to say that you've attended.
Oh, okay. All right. Cheers.
All right, so you won't have that bit yet.
All right. Cheers. Sorry.
All right.
Thank you. Thank you.
Hi, Aaron. You need to learn sign language. Did you get the answer to your question about the evidence? It was in the chat. Yeah, that's probably the case. What unit are you looking at? And I'll quickly have a look to see what my feedback says. Unit 8 trauma. Yeah, so the best way to remedy that is to do a Q&A on a trauma primary survey. You're not the only one who has had issues with the difference between a trauma primary survey and a medical primary survey. So just make sure you're familiar with the two. It'll be in your ambulance essentials book, and it'll be in JR Calc. LAS do a really good, if you type in LAS trauma primary surveys, you're a little action card on Google Images. It's absolutely brilliant. That'll take you through it all as well in a more brief summary than JR Calc will. All right. Remember to get yourself a cup of tea, guys, and a pee break if you need one before you come back in 1 minute's time. Right, guys, start making your way back for me, please. Pop your cameras on so I know you're there. Chloe. If someone, it was Rayon and Emma, I think. Did anyone else turn up slightly late? Just so that I've got it that you were definitely here. Hi, Chloe.
Thank you. Sorry about that.
That's all right, lovely. Is Kylie here as well? Yeah, you made it back. Good. Super. Right. So how did you all get on? Any questions with regards to your admin? Anything you found that came up that you wanted to ask about? No?
There's one bit on Unit 4 on the introduction that says you've got to upload something about student material. What's that about?
Is that level 4 workbook or level 3 workbook?
Level 4 on the introduction.
So level 4, let me have a little look. Hold the line. Oh, on the introduction of level 4 workbook?
Yeah.
Yeah, so that is just an additional piece of information if you need to upload anything, because there's nowhere on level 4 workbook to upload any evidence that you want to use. So for instance, some students use it to upload an appendix for their writing, or things like that. So that's just an additional place.
It's complete and it's done.
Yeah, so the introduction where it says evidence, yeah, at the bottom of page 1, it says
student material
upload. Yep. Yeah, you don't have to do anything with that unless you want to. It's just an additional part for you to upload a copy of anything you needed to, because there wasn't anywhere for students to do it.
Cheers.
Anything else you've got questions about, guys? No? Super. Right. In that case, let's carry on. So, portfolio submission. So some of you already completed it. And I've sent those off to different assessors to mark off. So some of you will notice that you're getting completed feedback once you've completed your portfolio. So if someone says, oh, I've had mine all marked off, don't think it's because you've been forgotten. It's because they've completed their portfolio to the very end. So once it's completed to the end, we can start sending it off to be marked. We do encourage you to get it submitted as soon as possible, because then that just allows you a little bit more time to get feedback, and that feedback to then be actioned if it needs to be. All right, so if you can submit it early, great. If you can't, then don't worry, it's just to the normal submission deadlines. As I said before, so it'll be marked by an assessor, and some of you may notice that the assessor moves from me, especially towards the end of your program. It is very unlikely to be me that is marking your portfolio in full. So just be aware that it will say at the bottom, assessed by. If you have any questions, you can contact that assessor, or if you're not sure, feel free to contact me as well, because I'm still your lead lecturer. So if you have any questions that you're not sure of, please feel free to ask me. It's not a problem. Just because someone else has marked your portfolio doesn't mean you still can't ask me. Okay. It does take time, as I said before, to mark the portfolio, so please just bear with us. And if you do get feedback to action, please action it. I know a few students on all the cohorts have still got things that they need to action from months ago. So just be aware that there's still some catching up and tidying up to do. I do try and send little reminders for the older units, just to probe you, to remind you that they need doing. So just keep an eye on it. If it's something, just check that your milestones are all up to date. So we talked about the IQA process. Your portfolio won't pass until it's been IQA'd. So IQA is there to make sure that I've done my job properly. So they will give feedback to me to say you've marked too harshly, or you've been too kind, which hopefully, because I've been slightly on the harsher side, none of you will get IQA information unless it's things like signature sign-offs and stuff like that. If I have been a bit too slack on my marking, you will get an email from the IQA saying you haven't produced enough evidence for this. So even though I've signed it off, the IQA may still come to you and say you still need to add some more evidence because they're picking up on my marking. But as I said to you, I've tried to be quite firm with you all on what is an acceptable level so that we don't have to then go through that process again. All right. But inevitably something will sneak through. There would have been a Friday afternoon where I've just missed something. So you may get something from the IQA just to say this needs adding. As I said, they must all be completed in that window of that by the 28th of February. But that's been brought back because the process takes a little bit of time. Not only from the assessor and the IQA point of view, but also from future quals. So once you've passed this course and you've completed and submitted a successful portfolio, I've marked it off. The IQA has said, yep, I've marked it off fairly. It will then go off to future quals for your certificate. Once you have your certificate, the world's your oyster and you go to your paramedic program. All right. Has anyone got any questions on the paramedic program?
Sorry, Heidi, can you just clear up? So if it's been submitted and we've had feedback, does that have to be actioned before we can start on the actual apprenticeship?
Yeah, you have to have a completed portfolio prior to your apprenticeship program. You can't go on to the apprenticeship program until you have a certificate that says you've completed this program.
Right. And
Makes sense.
Has anybody had issues with that so far? We've not sort of getting feedback actioned in time.
There's always a student that doesn't action feedback in time, always. But this is independent learning. We give you the feedback, action it. Once it's been actioned, we'll give feedback in a really timely manner, especially if you've completed your portfolio and there's only a few things that need adding.
Exactly.
All right. And remember, it'll only be smaller things, like unless it's a level 4, which I've had discussions with people and sent emails out, where some of you aren't reading the question. Unless it's a level 4 big bulk, your level 3 stuff will just be like, oh, just add this little bit or add that little bit. And like Aaron said in the chat, can it be added to the comments? Unless I have specifically said you can add this tiny little bit to the comments, it can't be. It has to be another piece of evidence. It will be little things like you've completed a how and what, but you've not wrote why on something small like completing EPCR records. Okay, so you can only add to the comments if I've said add this to the comments. If it's a large bulk of evidence, it will have to be done again. All right, or an additional piece added. Any questions? No? Cool. Well, there's a few little things that I want to just go over with you. Then we're going to do something called a pop quiz, which isn't sadly popular music. That would be quite fun. And then we're going to do a little bit of a review of your course, just with a few little things that I would like to know from you guys. All right. So a few things to go through. Aaron has mentioned one already, and that is trauma. Can you just reaction a bit you have said and get that signed off rather than resubmit the whole piece? So you have to submit, if you're going to do it like that, Louise, then you have to submit a whole new piece of evidence and have that signed off. So for instance, with a trauma primary survey, a lot of students have got confused between what a trauma primary survey is and a medical primary survey. Okay, so if it's a trauma primary survey, and I've said this isn't a trauma primary survey, you need to demonstrate one, you can do that through a Q&A or for a professional discussion and add that as a second piece. Okay, if it's wrong or bad practice, you will have to edit the whole piece. So if you're saying that you're going to you've gone to a major trauma patient with a fractured NOF and you've asked them to walk to the ambulance, that's bad practice, unsafe practice, so you'll be asked to rewrite that in whole. Does that make sense? Yeah. I love the way Louise types like this. She's sat there and then comes forward. Oh. All right. Good. Okay, cool. Right. So things like your trauma primary survey. Let's have a chat about that. Let's get the little things out of the way. So talk to me about a trauma primary survey. What would differentiate between a trauma and a medical? Let's start from the beginning. How does the global overview differ? Mic's on, guys. Come on, if your mic works. Can Come on. Global overview. What's going to be different on your global overview from a medical to a trauma?
Assessing injuries.
Okay, so on your global overview, absolutely. So we're looking for injuries, but you could get that on a SOB. You'll still be assessing for what the patient condition looks like, wouldn't you? So, but yeah, I agree. You'd be keeping injuries in mind.
Initial scene assessment.
Initial scene assessment, good. So what will that initial scene assessment tell you? Scene safety, good, Emma. But you do that for both, just in a different way, wouldn't you? So Gundala, tell us what are you specifically looking for?
Is it safe for me to be there in that area? And also it may give us an idea of mechanism of
Good.
injury as well.
Absolutely. So absolutely right. Same with Emma, same with Aaron, totally right. So you're going to be looking for cat hem. Now medical, you may find a cat hem. So for medical, you may find a cat hem on something like excessive GI bleed or something like that. So you may find it on medical. But you're absolutely right. Cat hem should be more focused because it can be an internal thing as well as an external thing. And then mechanism of injury. So that is instantly what you're looking for, aren't you? Because there's a big difference between walking into someone who's SOB or walking to the side of a RTC with a pedestrian versus car. Your mechanism of injury is really crucial to start thinking about, isn't it? And again, thinking about mechanism of injury from a child to an adult. So your mechanism of injury of pediatric versus car is going to be different. You're going to be looking for different injuries than if it was an adult, aren't you? Yeah, good. So then we're looking, that's our global overview, thinking about scene safety, things like that. What's the fire service role at an RTC, for instance?
Assisting with extrication.
Good, extrication. Before all that though, Vicky, you were going to say something?
Yeah, if it's RTC, they will secure the car if it needs securing before they let us approach the patient and start working.
Good. So if they're looking after us, what is their role?
Our safety.
Good. So our safety, so scene safety, that's their role from a point of view of stabilization. If they say you can't enter that car, you do not enter that car.
Yeah.
All right. Police, who are they looking after?
Everyone. Again, scene safety and scene management, especially if it's on a road or a busy road.
Good. And what else are they interested in?
If it's a crime scene.
Excellent. Well done, Kylie. So they're going to be looking at evidence collection, evidence stabilization to make sure that we don't walk all over their crime scene if we can avoid it. What's our job?
Our job is the patient.
Good. Excellent. It's the patient. That's what we're focused on. We're hoping the fire service is going to look after us and the police is going to look after them. We need to look after our patient. So if we say to the fire service, we need them out, the fire service is going to get them out quickly. Yeah. So bear in mind everyone's role as well in a trauma primary survey. So bear that in mind as well for your global overview. Are the fire service there? They're always there before us. Has anyone been to a job when the fire service is not there? No, they're pretty fast, aren't they? So fire service is always going to be there. But if the fire service weren't or the police weren't, what kind of things do we do to protect ourselves and protect the patient? Come on. Chloe, Jess, you're quiet.
Wear your high vis and your helmet if necessary.
Excellent. So PPE. What else do we do? Thinking about our vehicle.
The positioning of the vehicle.
Good. So we fend off, don't we? So before we've even touched or seen or looked at a patient, we've thought about all these things. Our safety, scene safety, fend off, our PPE, mechanism of injury, things like that. Yeah. Good. So we've done that. Now what? What comes after global overview? On a trauma primary survey. We've discussed it briefly.
Yeah, assessment of injuries.
Not yet. What comes first? Before anything else, what is our first letter?
Sorry, Heidi, will we do our assessment triangle first?
So your assessment triangle will come in your global overview, won't it? So your appearance, your work of breathing, your circulation to skin. Good. What is the C though, guys? Emma, Louise?
Looking for any cat hem.
Good. Cat hem. Cat hem becomes before C-spine, becomes before airway. Okay. Bearing in mind your trauma primary survey is what's going to kill them first. And a cat hem will kill them within minutes. So we spotted a cat hem. What are we going to do?
Do something about it.
Yeah, right answer. What have we got to do something about it, Vicky? What have we got in the bag? Plug it. Good, Louise. What are we going to plug it with?
Cat tourniquet splash.
What's it called?
Tourniquet. Good, Rayon. Sorry, Victoria?
I forgot the name of the bandage. The one we stuck in.
That's just things.
Celox. Good. What else have we
There
got?
you go.
So you've got trauma dressings, blast dressings. Do you guys have any good Emma blast dressings? Do you guys have any of the what's it? Sorry, go on.
Chest seals.
Chest seals you've got, brilliant. Have you got any of the packing? Does your trust allow you to pack anything? Chloe's nodding her head. Yeah, so you may have something with shellfish in normally that you can pack, that you can shove into holes and stop cat hem. What else have we got? Good old-fashioned response to cat hem.
Tourniquet.
Before that, tourniquet, because tourniquet is going to take you a while for you to look at the patient, go, huh, and then get it out. What have you got?
Direct pressure.
Direct pressure.
Good. Indirect, direct pressure. If it's cat hem, you're more likely to go straight for direct pressure. Indirect pressure is a good one. They used to teach butchers indirect pressure when they used to chop their legs off in accidents at work. But direct pressure is more likely what you guys are going to be going for. Straight on there, a good squeeze until someone's got that cat hem on. I got that tourniquet on. Good. So we've sorted cat hem. We're happy that it's stopped for now, yeah? Yeah? Good.
Yeah.
What's next?
C-spine.
Good, Louise. Airway, before C-spine. Airway, good.
Yeah,
so Louise has got that. Excellent. What are we worried about airway?
They've got one.
Yeah, but they've got one. It's kind of crucial for oxygenation that they have an airway. I agree. What are we not going to do on a trauma patient to clear their airway?
Head tilt chin lift.
Thank you, Jess.
Yeah.
I have read a few times, and this is the things where you'll get a rewrite, that to clear an airway, you do head tilt chin lift in a trauma primary survey. Please do not do that ever, unless they are in arrest, in which case they're dead anyway, so try whatever you can. That isn't what Jar Calc says. So bear that in mind, guys, all right? We're not doing a head tilt chin lift. What are we doing? Someone just said it?
Jaw thrust.
Jaw thrust, good. What else can we do, Emma? Emma. I saw you come up with having a mic on, so don't try and pull the silent one. All right, Chloe. Emma's mic has got you in the spotlight. What else can we do?
To clear the airway, sorry.
Yeah.
Use suction.
Excellent. Use suction. Suction. Good. Well done, Emma. Super. So we've got an airway. We could stabilise an airway with what? What could we put in to stabilise an airway?
An OP.
Yeah.
An OP. Good. What patients can we put an OP on it in?
Unconscious ones.
Good. Or patients without a reflex, gag
that-
reflex, so
yeah.
reduced GCS.
Unconscious.
Unconscious. Good. Yeah. What else can we put in?
IGEL.
NPA.
Good. iGel. What else, Rayon?
NPA.
Good.
Nasal.
Super. We could also do a really good C grip with a jaw thrust and get oxygen in that way if we're happy that if they've got a gag reflex and we can't get an airway in. Does an NP cause a gag reflex?
No.
No. Good. Why doesn't it
No.
cause a gag reflex, Rayon?
It's not in the mouth, it's in the nostrils, isn't it?
Good. So it actually sits just before it gets to your oropharynx. So your tongue all the way to the back. If you had a finger long enough and you reached into your mouth and hooked it up, you would then feel the NP. So the NP doesn't actually touch your gag reflex. So an NP is a brilliant, brilliant tool to have in trauma. Why do we put NPs in?
In case the mouth is too damaged.
Yeah, if the mouth's too damaged, but what purpose does an
For
NP
example.
serve? How does it help?
Creates an airway.
Yeah, how?
By allowing the air to pass up through the nose and then back in through behind the oral pharynx.
Good. So it's allowing a safe passage of oxygen, isn't it? What might be stopping that safe passage of oxygen otherwise?
Blood.
Yeah.
Vomit.
Yeah. What else? Don't
facial
make me.
trauma.
Yeah. Don't make me
None.
make you all blown your nose.
Oh, secretions.
Yeah, secretion. So a good load of snot, especially if they've been stressed, they'll definitely be pouring with facial fluids. So absolutely. So an MP doesn't actually hold an airway open. It just makes it easier for the oxygen to flow through. So please don't rely on them for a patent airway. Okay. An MP also won't hold the tongue out the way. Okay, doesn't go anywhere near your tongue. It doesn't go past your tongue either. It sits above, like I said, just at the start of your oropharynx, not your nasopharynx. So it will come round and sit about here. All right. So it won't hold a tongue out the way. What does hold a tongue out the way?
NPA. OPS, sorry.
Good. OPA. And the other one we talked about?
Gels.
Igel. Good. So what is your biggest cause of an airway occlusion?
Tongue.
Commonly thought to be the tongue. It's not. Do you know what it is? No, well, positioning will definitely make a difference if you're large, but if you're not large, Chloe, if Chloe falls over and falls back, what do you think might occlude her airway? What's very floppy and limp while she's unconscious? That's not her tongue.
I don't want to comment on that one. What's in my head?
This is also toilet seat in sign language, so I probably shouldn't be doing this. What did someone just say? I think they just said it.
The neck.
It's in the neck. We'll get that far. It's at the end of your oropharynx.
Tonsils.
Come on.
Is it a pharynx?
What's in your pharynx? What's it not in your pharynx? It's in your larynx. What's in your larynx?
The voice box?
Do this, everyone.
Epiglottis.
Yay! Who said that?
Glottis, oh shit.
Good, Kylie. So your epiglottis is now actually the most common cause of airway obstruction. It's not tongue. So we do a lovely jaw thrust that we think, oh, that'll sort the tongue out, and it absolutely does. But we've still got the floppy epiglottis to worry about, especially in paediatrics. So OPs and MPs are great, but if they're unconscious, we really want to be getting that eye gel in nice and early to get that epiglottis well out the way. Okay, good. Airway, next.
Breathing.
No, more important than breathing.
C-spine.
Good, C-spine. So what are we worried about C-spine? Why is it a problem? Give me the old-fashioned riddle. Come on, Dinelli. What's the?
Oh, I don't know the riddle.
The old school riddle.
We don't want them to have C-spine damage, and if they do, we don't want to make it any worse.
Good. And what can C-spine damage do? There is, come on, someone must know this. Someone who's been in for many years must know what the riddle is. For C3, 4, and 5.
What, paralysis?
Who just not paralysis? Well, it will cause paralysis, but C3, 4, and 5 keep the
patient alive.
You're clearly there. On the diaphragm alive. Diaphragm's responsible for your breathing. So C3, 4, and 5 has got the nerve that controls your diaphragm. If the diaphragm knocks out, you ain't breathing. So if the patient fractures 3, 4, and 5, you knock their diaphragm out. So these are really important. Bearing in mind that 1 and 2 you can't palpate because they're inside the skull. So the atlas and the axis, 1 and 2, you can't palpate them. So the first one you can palpate on yourself is C3. Okay. C3, 4, and 5 keep the diaphragm alive. If they're complaining of a really high up neck pain, you've got a problem and that patient needs serious stabilization. If the patient's doing this, I feel like my head's going to fall off. That's an atlas and an axis problem, and the head probably is going to fall off. So bear these in mind. Your C-spine is crucial. So don't forget it, because we're quite flippant with that these days, aren't we? Because we don't see it genuinely very often, do we? So bear it in mind. Good, we're done C-spine. Next. Breathing, good, Vicky. So breathing, what comes under breathing in a trauma primary survey? First things first.
Are they breathing?
Are they breathing? So what's important to take note of in breathing?
Rate, yep.
Rate,
chest rise and fall.
Chest rise and fall, but rate, rhythm and depth. RRD is what we're looking for. Or rate, effort and depth if you want to do red flaps. Did you guys ever learn red flaps?
Yeah.
Yeah, some of you may have, some of you may not have. So red flaps, rate, effort and depth. So is their rate fast or slow? We're not interested in a definitive rate at this point unless you've got a spare person to hand. Because when are we going to assist ventilations for this patient? Above and below what?
6, I don't know.
Is it above 40?
Over 20, maybe? Over 20, less than 12?
No. You're not far off, though, with your 12. Less than?
10.
10, good, Danelli. And more than? Good, Emma. More than 30. Good, well done, Emma. More than 30. Excellent. Okay, so the rate, we just want to know if it's fast or slow. The effort, we're going to, or efficiency, like you're saying, or efficacy, whichever E you prefer to use. Absolutely. Is it adequate? Because if they're shallow breathing, is that adequate? No. So we need to make sure we're assisting their ventilations. Yeah. Depth, we're interested in depth because we want to know if it's a little or if it's a lot. And we want to know if they're really struggling or if they're barely breathing at all. So rate, effort and depth is important. Flaps, let's quickly go through your flaps. We should know these like the back of your hand. Chloe, give me an F.
Feel.
Good. Kaylee, an L.
Look.
Good. Jessica, an A.
Auscultate.
Good. Louise, a P. And while she's typing that, Aaron, an S. Good. Palpate or percuss. Good. Search. What are we searching for, guys?
Blood.
Blood. Good.
Injuries.
Good.
Yeah.
Injuries. Excellent. We're really having a good search for injuries. And this is where we're going to go all the way around the back of their ribs and check for blood on our gloves as well. Good. Feel, look, percuss, search, and auscultate in the middle of that as well. If we find a problem with any of those, what are we going to do? So say, for instance, sorry, go on, Denali.
Rectify it.
Good, rectify it. What if we can't rectify it? What if we come across a flail chest? So you find that there's something wrong. For instance, you find that there's a tension pneumothorax and you're working with Aaron. Who are you going to call? It's not Ghostbusters.
That was my first thought. A grown-up would be my second.
At least you hesitated and didn't say it. A grown-up. What are we calling a grown-up in professional terms?
Somebody that has the skills to deal with that.
Good. What condition is that?
A paramedic or a doctor.
Good, paramedic. So we'll go for a paramedic. So paramedic's going to turn up. They're going to decompress the chest. They're going to go, that's the first time I decompressed your chest in a long time. That went well. I've bought myself about 90 seconds before it happens again. So I think, I know, instead of just sticking a needle in someone's chest, I'm going to ask for someone to come in and slice their chest. So now I need a grown-up. So I'm going to ask for a doctor, or I'm going to ask for a critical care paramedic. And they're going to come and they're going to be heroes in their orange suits and they're going to fix our patient and fly them off to hospital. Happy with that? Everyone lives happily ever after. However, you ain't got one. There is no para, there is no doctor, you're on your Todd. So you're doing the best you can. So you found a flail chest or you found a pneumothorax. What's your treatment at this point if you haven't already done it?
High flow oxygen.
Good. So high flow O2 on all trauma patients should go on an A. If you then determine that they don't need it later on, that's great, take it off. All right. But that high flow oxygen is what is going to keep them alive. We'll talk about the trauma triad of death in a little while. Good, so we've done B to red flaps. What else on a trauma primary survey is really important at B?
12.
12, good, Rayon, you volunteered yourself well for a T.
Check, yeah. Check.
Good.
Check.
And what are we looking for with the trachea?
Any damage, any sort of out of place.
Good, so tracheal deviation. If the trachea is deviated, what does that mean? Other than their death is very imminent.
What, me? Still me?
Sorry?
Is that still me or?
Anyone, I'll open it up.
A pneumothorax.
Good. So we've got a tension pneumothorax. That tension pneumothorax has dragged the collapsed lung and pushed the tension in lung across so much that it's pulling their trachea. These guys are going to die imminently. If you haven't got someone there quickly, you're going to watch a patient die. Cheerful. W?
Wounds.
Good. Well done, Chloe. Wounds. Why are we interested in wounds on the chest? So bearing in mind 12s is only from the nipples up. Why are we interested in wounds?
I suppose just to check for any damage to the lungs, possibly.
Good. So we're looking at any damage to the upper lungs or the upper airway. Good. And we're going to fix what we find, aren't we? So we've got Nightingale dressings that we can use. What dressings do you use for your escape? Things like a stabbing. Chest seals. You use Russell chest seals? Good. Super. So, yeah, Russell chest seals, should be looking at things like that, won't you? E? Who's got E?
Is it emphysema?
Good. Surgical emphysema. Good, Aaron. Different to normal emphysema. What is surgical emphysema?
It's like bubble wrap.
Good.
Under
So
the
the
skin.
best way I can describe it is someone has a crisp packet under their skin. Absolutely right, Emma. It's air escaping. So it's air where it should not be. And when you touch it, it feels like someone's put a crisp packet under their skin. I've only seen it twice, and both times I've gone, that feels just like a crisp packet under their skin. So that's what it's like. Again, bad news, depends on how much there is or where it is, depends on whether they are really sick or just a little bit sick, but either way, we don't want it there. All right. L? Everybody do this?
Larynx.
Good, your larynx. And what are we looking for? Good, Aaron?
Any crepitus?
Good, well done, Chloe. So pop your hands on your larynx for me now. This is going to be awful and you won't enjoy it, but it's really important. And you wiggle it from you wiggle it from side to side. Wiggling it from side to side. Good, Aaron, changing point voice pitch. We'll talk about that in a minute. Wiggling it from side to side, you'll have a little bit of crepitus in there. Okay, it's when it's really starting to crackle and snap that we've got laryngeal crepitus. If you spot that, you leave it well alone. So we'll have a change in voice, absolutely, but say they're unconscious. What is going to be the main mechanism of injury for these trauma patients? Where are we most likely to see a laryngeal crepitus?
Would it be on somebody who had an RTC if they've been on a motorbike?
Yeah, so if they've hit something like a lamppost, absolutely.
Would a hanging?
Exactly, Jess, well done. So a hang-in is where you're very likely to feel this. So if you go to a hang-in and they are dead, ask the paramedic that you're with and make sure that the family aren't near you. Ask if you can just feel for that crepitus and see if you can feel it, because that is the best way to learn. All right, don't be doing it in front of the family, obviously, and always ask permission first. And if it is appropriate, so that it's not suspicious, because obviously if it's a suspicious hanging, then don't touch the patient, otherwise you'll be incriminated. But have a feel, see if you can notice it. Good. Right, where do we get to? So laryngeal crepitus, what's V?
Veins.
Good. Where are we looking for those veins?
The jugular vein.
Good. So venous distension, what does that tell us?
That there's potentially like an obstruction or something.
Okay, and what would be causing the engorgement of that venous distension of our jugular vein, though? What clinical condition?
Is it sort of showing that the heart's having to work hard?
Good. So what might it be?
A hemothorax.
Potentially, but more likely a reversible cause. Requires a big injection into the heart to remove stuff. Good. Well done, Aaron. Well done, Emma. A tamponade, cardiac tamponade. That's what's more likely to cause that. Hemothorax and pneumothorax can also cause it, but if you're looking at trauma to the chest, always think about a cardiac tamponade. All right. Good. And then E is nice, easy one. E 9 times out of 10 is
Evaluate.
exactly evaluate. So decide how bad they are based on what you found. Good. So we've done our breathing, which is very different to our primary. Do we agree? Of a medical primary. Yes, no?
Mhm.
Give me some thumbs up or some thumbs down. Good. And then what comes after B?
Circulation.
Circulation. Good. So what do we look for in circulation in a trauma patient?
Blood pressure.
No, we're not doing any observations on the patient at this point unless there's another pair of hands. So observations do not come into a primary survey, either trauma or medical, unless you have a spare pair of hands.
Palpable pulse.
Good. So we're looking at what of our pulse?
Radioactive.
Feel it.
If we can feel it. So the depth. What else comes in it?
The rate.
Rate, fast or slow. What else are we interested in?
Regular or irregular.
Good, if it's regular or irregular. Super, well done. So we've done that. What else comes under C in our trauma primary survey? Because that's the same as medical. What's the little addition?
Blood on the floor and 4 more.
Good, Chloe. Blood on the floor and 4 more. Good, Louise. Cap refill is another one. What is our 4 more?
Chest, abdomen, pelvis, and long bones.
Good, clap. Chest, long bones, abdomen, pelvis. If you can't remember, don't do this on the side of the road, but just think of a Mexican clapping or a Spaniard clapping in a wonderful dance. And remember that, chest, long bones, abdomen, pelvis. Okay, they're what you're looking for. Talk to me about a pelvis assessment. Chloe, if it's you that I remember writing about it, tell me about a pelvis assessment.
You and me?
Yeah.
Yeah. Not to palpate or like manually sort of move it.
Good. We are not touching it other than to put a splint on it. What splints do you guys use for pelvises? Do you use binders, SAM splints?
Binder.
Binders. Cool. So we are not going to palpate it. We are certainly not going to spring it. That is old, dangerous practice. Okay. What are we going to look for, Chloe?
Things like the open book presentation.
Excellent. What else? Anyone else?
Training groins.
Good, but they may be unconscious. If they've shattered their pelvis, chances are they're not going to be very conscious. Or if they are conscious, they're not going to be asking you. You're not going to be asking if they've got a pain in their groin because they probably have.
Incontinence.
Good. Incontinence. Excellent. Different leg lengths. Absolutely right. And symmetry. So sometimes we have a shearing of the pelvis. Has anyone heard of this? So bearing in mind your pelvis is a polo. Okay. What happens if you break one part of a polo?
Break another part.
Absolutely. You can never break a polo in one place, can you? Your pelvis is exactly the same. If you fracture one part, you fracture another. And that can determine whether you have a shear or whether you have an open book, or sometimes whether it's got neither and it's just a tiny little fracture or a cartilage break. Splayed feet is exactly right. So with an open book, you'll see that both their feet are splayed out like that. We obviously have a natural splay where our toes don't touch the floor. If they have an unnatural splay where their toes are touching the floor, you've got an open book pelvis and you definitely need to be binding that up. Why do we bind?
For potential bleed.
Kylie, say again and then we'll go to Vicky.
Reduce the blood loss. Good.
So you want to stop bleeding? Absolutely. You're right, Louise. You're right, Emma. Vicky, what were you going to say?
Saying they can bleed up to what, 4 liters into their pelvis. So
yeah, I think it's 2 liters for a pelvis, but don't quote me on that. But there's a lot of blood either way, isn't there? There's a massive amount of blood volume. So yep. So we want to try and stem the bleeding. What else?
If we put a binder on it, it'll make them a lot more comfortable.
Good. So exactly right. So it'll reduce pain. It will offer support. You're right. What else? Good, Emma.
Offer support for extrication as well to reduce any further damage.
Good. So why do we need to reduce mobilisation when we move them? What might have formed?
Clots.
Good. Excellent. So if we've got a patient who's had trauma and we've put a binder on them, or we haven't put a binder on them. If we not put a binder on them and they've formed a clot in the 20 minutes it's taken us to get there, and we then move them around, we're then moving the clot. That body has just worked really hard to try and stem a bleed, and we've gone in heavy-handed moving them around, and we've dislodged a clot, and they've started bleeding again. So even if you're not sure of whether their pelvis is done or not, I would always consider a pelvis for major trauma. If they've done enough damage to cause a flail chest, an open pneumothorax, if they've done enough damage to do a femur fracture, I would absolutely be pelvic binding them, because it takes a lot to break a femur. Make sense? Good. So we've done blood on the floor and 4 more. Our 4 more, we've thought about splints. Chest we've looked at. We can think about asking for a doctor. Long bones, what do we use for long bones?
Box splint.
Good. Box. We don't really want to be splinting long bones, but we've got a splint. What kind of splint other than a box splint?
Back splints.
Say again?
Got vac splints stuff.
Oh, I love a vac splint. I'm dead jealous if you've got them. Good, Emma. Traction. So what traction splints do you have, guys?
Got the Kendrick.
Kendrick device. Excellent. Can you use the Kendrick device on a humerus?
Nope. No, you can't.
So the one with a little pole you're talking about, aren't you, is your Kendrick?
I thought that was the one with the look like a crutch.
Oh no, not that one. That is that's a, I want to say KED, but that's not right either.
Sega.
That's a Sega. Yeah, that's
There you
I should remember that because it's an old computer game, old
Yeah.
computer system.
I believe you can with the Kendrick, but you can't with the Sega.
You absolutely cannot with the Sega. That would be funny.
Yeah.
But you can with the Kendrick if your trust allows. So it will go on a humerus if your trust allows you to use it for a humerus. All right. So yes, Emma, you're right. You can use it. Just make sure your trust recommends it. All right. Good. And then what about abdo? What can we do for abdo? We've got a distended abdo that is very bruised and very hard. What do we suspect?
Bleeding.
Good. How are we going to stop the bleeding?
We
Think
can.
like you physically can't. Think like a para.
TXA.
Excellent. TXA. How soon does TXA have to be administered to be immediately effective?
Soon.
Yeah, give it to me in minutes. Soon's great, Kylie. Give it to me in minutes.
5.
40. In the first 40 minutes is when it's most effective for a bleed. What's the maximum you can go before it's ineffective or practically ineffective?
2 hours.
You're close.
Hour and a half.
3. So 3 hours. Some textbooks will tell you 4, but the Crash 2 trial has diminished that theory and it's 3. All right. However, if your para's taken 3 hours to turn up to give TXA, I would question why you're still on scene. All right. Good. So that's our circulation. What else are we going to consider at circulation? So we've talked about cap refill. What else are we going to think about?
C's, 4 C's.
What are your 4 C's? This is new round. Tell me about your 4 C's.
Your cut tourniquets and stuff.
Good. Absolutely. I've never heard of it put with the 4 C. But we need to rethink how our cat hemorrhage is doing, because we may have put a tourniquet on and thought, brilliant, I'll move on. But actually, as we go back, it's still weeping. So we need to reassess our cat hems at sea.
Check your dressings and fluids and stuff. Consider fluids.
Cats or fluids, did you say?
Consider fluids.
Consider fluids. Okay, good. Yeah. So if our blood pressure is a little low, now fluids are an interesting one, and I would recommend reading the JL Calc for it for you guys at the moment. But when it comes to being a paramedic, there's a lot of information out there with regards to when you should give fluids and how much you should give fluids to. So we won't go into too much detail of that today, but depending on what type of trauma, whether it's penetrating trauma, whether it's what's it called when it just hits you? God, I need more sleep. Depending on what trauma it is, depends on how much fluid you'll give. Thank you, blunt force trauma. Thank you, Denali. Thank you, Emma. Then you'll give a different type of fluid because you want to aim for a different type of blood pressure. So not all trauma patients, in fact, I would never let a trauma patient's blood pressure get above 100 because I want it nice and low, because I want to make sure that we're perfusing well, but also making sure that we're not dislodging clots, which is what the problem is with giving fluids. And I want to make sure. Oi!
Most.
Shush! I reckon it probably is actually. Yeah. Manford, enough. So we don't want to dislodge clots. So we need to make sure we keep a nice low blood pressure, because if we increase that blood pressure, we're just pushing clots out the way that we've just perfectly formed, and this patient's worked really hard to keep. So blood pressure is a really interesting one when it comes to fluid therapy rounds. So just be aware of that. All right. Cool. So let's see. What else can we think about at C when we talk about cap refill? What are we doing when we do a cap refill on a patient? We're going to touch them, aren't we? What could we note?
They're cold and we might need to warm them up.
Good. So careful. So warming up a patient is dangerous. Cooling a patient is dangerous. We do not, in the pre-hospital environment, have the facility to warm or cool effectively and safely. All right? We just don't. We have a tympanic and we have our finger to see if they're warm or cold. That's all we've got. That is not a controlled environment by any means, is it? And depending on whether you're trying to cool them or warm them, depends on what damage you're going to do. What you must make sure in trauma patients is that you do not let them get cold. You will kill them if you let them get cold. Okay? So don't actively warm them, just don't let them get any colder. If you try and warm them up, what happens when you warm a body up? What happens to our blood vessels?
They dilate.
They dilate. If you dilate blood vessels, what's going to happen to that bleed?
It's going to keep going.
It's going to bleed more. You've basically just turned your tiny little hose pipe into a massive firefighter's reel. You're going to make them bleed blood quicker than ever. Okay, so we don't want to actively warm them. We don't want to actively cool them. We just don't want to let them get any colder than they are. All right. Good. So D, what comes under D?
GCS.
GCS, good. So GCS does not come up in a primary survey for medical. We only do a formal GCS in a trauma. Why?
So we need to see if there's any neurological damage.
Good. And what neurological damage are we specifically looking for and why? Head injury, good. So we'll do head injury is good. We'll do a head sweep. So if we do a head sweep and we've got a depressed or open skull fracture, what might that be? What does that mean for this patient? Jess? What would a depressed or open skull fracture mean for this patient? What have they now become from a trauma patient to a
major trauma patient?
Good. Who said that? Miley. Good. So major trauma patient. So we've now got a major trauma positive patient rather than just a trauma patient. Why does that matter, Jess?
You need to go to a major trauma hospital.
Good. So we need to get them to a major trauma centre rather than the trauma unit. Good. Well done, Emma. Good. So that's our head sweep. But thinking about our GCS, what is GCS important? What comes under our major trauma positive for motor score? No takers? So do you guys ever get given a major trauma card to see what your indicators are? No, I would recommend getting a copy for you, because if your patient is major trauma positive, they need to go to a major trauma centre.
We do
So
have tab tools.
Got the top tool on EPR, yeah.
Excellent.
So if you click that, it will then give you the criteria to meet the major trauma centre.
Perfect. So that guidance will tell you that a motor score of 4 or less will get you a GCS. A GCS motor score of 4 or less is a major trauma patient. Okay. So that's why GCS is calculated formally. Pupils equal random reacting to lie. Absolutely, Emma, you're right as well. So we're doing a pupil assessment. Head sweep, we've already talked about. Anything else in D? I don't think there is. Do we do a fast test in a trauma patient? No? Good. So BM absolutely needs to be considered, Louise. So BM is an interesting one, dependent on trust and dependent on paramedics. So BM is an invasive procedure that doesn't necessarily have to be done unless you've been given cause to think so. A patient who is unconscious absolutely needs a BM, 100%. Anyone with a reduced GCS needs a BM, because they may have been on a motorbike that they've crashed because they've had a hypoglycemic event or a hyperglycemic event. Yeah. So BM, good. A formal temperature at this point. Do you guys have tympanics?
Yeah.
Yeah, super. Did anyone remember a time when we didn't have tympanics and we had these little plastic dots that you put under your tongue, temper dots they were called?
You still got them.
You still got temper dots?
Yeah.
Yes, alive and well. Oh man, yeah. So before you had tympanics, you still got them, but them as well. They were always fun. So temper dots, yeah. Again, not reliable. Tympanics better, but still not brilliantly reliable. But that's this formal temperature. What we need to do is make sure we establish a baseline. So even if it's not great and it's saying like the temperature is 35.9, that allows us a baseline to see if they're getting hotter or colder. Yeah, we do not want that patient to get colder. Good. So what's E?
Suppose environment.
Environment, evaluate, expose. So what are we evaluating for this patient first and foremost? If they're what? What's the whole point of a primary survey?
You like injuries that needs urgent attention.
Good. So if they've got life-threatening injuries, what does that make them?
Time critical.
Good. Thank you. Who was that? Was that Kaylee?
Yeah.
So they're time critical or non-time critical. That's what we're first trying to establish, isn't it? Are they really poorly, or they're just fallen over on a football pitch and got a sore ankle? Time critical or non-time critical. So we've established that they're time critical. What's our next thing we need to establish? We've talked about it already.
Where they need to go.
Good. So major trauma positive or major trauma negative? And that's absolutely right, Emma and Louise and Aaron as well. So we're looking at where they're going to go because of major trauma centres. Now, where I live, we don't have a major trauma centre within 45 minutes. Our nearest major trauma centre is about an hour and a half away. So we will always go to our nearest trauma unit. But you guys have got quite a few down there, haven't you? So that's something you definitely need to be aware of, taking them to the right place. If you don't take them to the right place, then they're not going to get there. They're not going to get the treatment they need and they may die. Other resources needed, absolutely, Aaron. So hopefully at this point, if you've established that they're really sick and they've got a tension pneumothorax, they've got, can you guys put traction splints on? Yeah, good. But if they've got something else that you can't assist with, then hopefully you've called for backup at the point you need it. If you can't, if you find it, you fix it. If you can't fix it, you ask for help. And that's what we go through. Good. Is that the same as a medical primary survey? No, it's not. It's absolutely not. So please, 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 please be aware of that. All right, guys. A primary survey, a medical primary survey on a trauma patient isn't going to help you at all. It'll get you through. It won't tell you everything you need to know. It certainly won't tell you whether they're major trauma positive or not. Have I talked to you guys about what happens when you pre-alert and you do an atmister? Have we talked about the hospital?
Yeah.
Good. Super. So we all know the importance of that early pre-alert, don't we?
Yeah.
Excellent. Good. Super. Well done. See, it is in there. Just got to get that on the paper. Right, we weren't going to do a pop quiz, but you've all answered questions very well. There's not been anyone who thought they could get away with not answering a question there, so good work, guys. So we won't do the pop quiz because you've answered loads of questions already. We were going to talk about trauma triad, weren't we? Have you heard of this? Have I told you about trauma triad of death before? How to keep your trauma patient alive? So I'll quickly show you this image. Okay, this is a trauma triad of death. Okay. If you want your patient to die, this is the quickest way to do it. All right. It's basically a vicious circle. Okay. So we'll start from blood clotting problem. So if we get a coagulopathy problem, so what could cause a problem with clotting?
An anticoagulant.
Keep their own blood thinners.
Yeah, that is your worst nightmare. We do not want that. So if they're on blood thinners, that absolutely will. What else will cause their blood to become extra thin? Rayon's talked about it already. Haemophilia, so a medical condition, yeah. But think more about our interventions. Alcohol. Hopefully we're not going to give them alcohol.
Temperature.
No,
This will
they've
cheer
had
you up.
alcohol.
Good. Yeah. Who said temperature? Good. That will affect it. Rayon, what did you say you were going to give? And I said be careful with what you give.
Fluids.
Fluids, good. That will affect it. And what else will affect it? The answer's on the screen. A build-up of...
Acid.
Good, lactic acid. So if
Yeah.
your patient is not well oxygenated, they'll build up lactic acid. Everybody remember anaerobic and aerobic respiration from GCSEs? Drag yourself back there. No? Remind yourself, it's good to know. So anaerobic and aerobic respiration, if you're not burning off oxygen, you start burning off what?
Carbon.
No. Come on. I can hear you all going, oh, like painfully trying to remember. Sugars. You burn off sugars. Okay. The outgoing of burning off sugars is lactic acid. The only way to reverse lactic acid is... Oh, don't make me all get you to run all on the spot. Not fluid. That will reduce it, but it won't fix it. Aaron, you look fit and healthy, my man. Stand up. Good. Oh, you've recovered yourself well. You can sit down, mate. O2. So when you go for a run and you run really fast on the spot, what hurts?
Legs.
Legs. That's a build-up of lactic acid. When you stop running, does your breathing instantly go back to normal?
No.
No. What happens?
You have a
What happens to your
recovery
breathing? Good. You're still puffing, aren't you? Puffing out your arse. You're still going... That's because your body's trying to take on that oxygen to reduce the lactic acid, and then your pain goes away. It's exactly the same. They just haven't run. So they're getting a build-up of lactic acid. We need to reverse that lactic acid with O2. If we don't, we stop the clotting process. Okay? So we have an increase in lactic acid, which causes acidosis. Okay? Acidosis is awful for the blood. It thins it out. It makes it really hard to clot. A low body temperature also decreases coagulation, so it can't clot because it's cold. If they can't clot, they'll bleed out. If they're bleeding out, they'll have an increase in lactic acid because their body's trying to burn stuff that can't carry oxygen because there's no blood to carry that oxygen that it needs. So it'll start burning lactic acid. Lactic acid then causes a problem with low blood pressure, low temperature, and it causes a problem with coagulation. If we get a low hypothermia or low temperature, then we cause a problem with coagulation. If we've got coagulation, we can't clot. Do you see how the quickest way to kill your patient is? What are the 3 things we need to ensure, if nothing else, to make sure your patient as an ECA stays alive? The most basic things we can do. Go on, Danelli.
High flow oxygen.
High flow oxygen.
And a blanket.
And a blanket. What else? We need the blood to oxygenate. If we haven't got the blood, we can't oxygenate. So what do we need?
Stop bleeding.
Stop the bleeding. Absolutely. Those 3 things alone will save your patient's life. And those 3 things, ironically, are the things we are the worst at pre-hospitally, aren't we? How many times have you been to a really sick trauma patient and they're about C or D when someone's put a pulse ox on? Do they think, oh, better put O2 on? How often does that happen?
Often.
Yeah. It's not just trust specific, that's across the board. So bear that in mind. Oxygen early, really, really early. Give every last little blood they've got. Get it full to the brim of oxygen, because if they're going to lose that blood, you want all the blood that's left to be absolutely bursting with the stuff. Yeah. Get a clot quickly, so stem that bleed. Okay, catastrophic hemorrhage, more importantly, obviously, get that stemmed. You can't have that blood, that valuable blood leaking out, because we need that oxygen. Without the oxygen, we get lactic acid. With lactic acid, we get an increased bleed. And hypothermia. We need to strip that patient down on a trauma primary survey, no doubt about it. But as soon as you have finished stripping them down, you cover them straight back up. Because again, I've seen it so many times. I've turned up and there's a patient with a blanket over their lap with their chest fully exposed. Like, the least valuable part of their entire body is their legs. Why are you keeping that warm? Their aorta, their heart, their lungs, their kidneys, their brain is all up here. Putting a blanket over their legs is worth nothing. All right? Blanket over the head to keep their head warm, because it's obviously where we lose heat. It's why your mum always made you wear a hat as a kid. And make sure that you're keeping their core warm as well. If they're laying on the floor, you need to get them off the floor as quick as possible and safely possible. Okay? One on top is worth two underneath. Normally gets a snigger, that, but bear it in mind for blankets. Okay? If you can get more blankets underneath, that's why homeless people sleep on newspapers, because it's just a deterrent from the cold. So get them off the floor as quick as you can. If you can't get them off the floor, say for instance it's a massive mass casualty incident and you've got your patient on a scoop but there's no trolley to put them on, please, please, please put them on a rolled up blanket underneath, okay? Or at least a laid out blanket underneath, but get them off the ground whilst you're waiting to move them, all right? Because keeping them on the floor, you'll kill them. They'll die, and that will be your fault because it will be reversible. Could have been totally avoided. No pressure. Having paramedicing. Cool. Any questions, guys? Silence. O2 and blankets, absolutely, Louise.
What if you can't stop the bleeding? What's then?
Okay, so what would you keep doing if you can't stop it? What have you tried so far, Rayon?
Oxygenating and like doing the normal airway, maintaining airway and stuff like that. But
what have we done to stop the bleed? So we're going to give a. You said it earlier on. What's the first thing we're going to put on?
Dressings and stuff. Obviously, get your blast dressings and whatever you can on.
Okay, so we're going to look at direct pressure, aren't we?
Yeah.
Whilst someone's getting a dressing ready. We could look at a cat tourniquet. We could look at a cat tourniquet with a dressing. We can look at a cat tourniquet with a dressing and direct pressure. What if we can't? We can look at that plus TXA. What if we can't get that to stop? What do we do?
Panic.
You panic internally. I'll let you have that. Sit on them, Louise. Oh, probably frowned upon. What will we do? Do we think
get them to hospital?
Good. We can look at moving them to hospital. Absolutely right. Look at calling the doctor. Do we think, oh, never mind, I better move on to airway?
Add another tourniquet.
Add another tourniquet. Excellent. So just slightly above. Keep redressing. Good. So if it soaks through too, remove and start again. Get that pressure on. I mean, we laughed at Louise saying sit on them, but actually, if you need to dig your elbow into that bleed and put all your weight on it, then you put all your weight on it. If you need to kneel on that patient to get them to stop bleeding, you kneel on that patient to get them to stop bleeding. You do not move past catastrophic hemorrhage until you have stopped it. There is no point moving on to A just because you can't fix cat hem, thinking, oh, well, I can't fix that, I'll move on. Because they won't have an airway in about 5 minutes' time because they'll be dead.
I'll cut you off. Like, well, I've been to a serious incident on the motorway, and that it was a 10-year-old, and he had like a massive like slash to the side of the head.
Mm-hmm.
And when we got there, like I was there, obviously they was doing CPR, but the HEMS got there eventually.
Mm-hmm.
They didn't even like touch the head. They just went straight to doing CPR and all that. And there was it was massive, but I don't know if it's just they couldn't do anything about it, or it's just like it was just left there.
So explain that to me again. The 10-year-old was left there.
Well, yeah, it was on the obviously middle of the road. We didn't have any sort of like much, but obviously HEMS came and then they just like crack on with it, like terms of like doing like ALS and stuff. They didn't do anything to the head. They just left it there.
Was the head bleeding? Was it catch? I mean, it's unlikely you're going to get a catastrophic hemorrhage from the head.
It was really hard. It's like all that was going on. It was hard. It wasn't like obviously pouring face with blood, but you can see that, like you can see the big slash, like by the side.
Yeah, so that's not immediately life-threatening. So even a degloved head is not, unless it's pulled an artery off, it's not going to be an immediate thing for you to react. And this is what's really important as you move forward as clinicians, is you do not get distracted by little things like a tib-fib open fracture. Because a tib-fib open fracture is limb-threatening, it's not life-threatening. A sliced head is going to be a really bad scar, it's going to cause infection, it's going to have massive complications, but he's dead. He needs full ALS, and not only just ALS, he needs the HOT principles. So you need to make sure that he's being offered everything from.
He was dead. He was dead. Boy.
Yeah. But it's different when it's in cardiac arrest.
There was just no one to go there. We drove 30 miles to that incident. We was the first on scene. Drove from London to that to nearly Northampton on Junction 9. There was no ambulances.
Yeah, that's sad.
4 and a 10-year-old, yeah.
That's really sad. Well, thanks for that cheerful end to the tutorial, Rayon.
Sorry.
Brought the tone down nicely for us all to leave on. Cool, right. Just before you go, guys, if you haven't got any more questions, can I just quickly ask for a little bit of feedback based on your tutorials? So we're currently in the process of reviewing all 4 tutorials, or 5 tutorials, including your induction. What do you think would have been helpful to have earlier, or what do you think would have been more helpful to have had later? You what?
This sort of chat.
This sort of chat. That's the thing. People think that the bridging program is actually a teaching program, and it's not. It's a transition of your qualifications. So teaching is wonderful, and it's what I love doing. But sadly, it's not what the program is. What did you? The what, how, and why? Did you all get that early enough? Do you think that would have been more beneficial?
I think it was earlier.
Sorry, go on, Denay.
So yeah, I think it's difficult where we're kind of, like you say, it's about us doing the learning, it's distance learning. But what's difficult is you submit and then kind of have the tutorial about what you've just done, as opposed to what you're moving on to.
Good.
It's almost ask about pace. And the other thing that I've realised once I'd done Unit 8 on level 4, my son's laptop's got Word, but I was using WordPad. And obviously that comes as part of it. So people knowing that they've got access to Microsoft Office from day one would be really helpful.
That's a really good point. So your tutorial sooner, I've raised that as well, because I've noticed as we've been teaching that you got told after you'd started writing. So I've reversed that and put it in the induction. So brilliant. I'm glad that that's what you agree with.
You must find that you're giving us all the same feedback, that actually once we have the tutorial, that feedback, most of that wouldn't be necessary because we would have learned it beforehand.
Absolutely, I agree. Knowing about Word is actually really useful, because you're right. That's great to know. So I'll put that in the tutorial as well. Knowing Word is available free. Cool. Anything else?
Some of the tick boxes are duplicated. Like I'm doing Unit 7, and they're exactly the same wording but duplicated to different points. So that is confusing. The oxygen ones as well. They're duplicated.
Yeah, so oxygen ones, there's a reason oxygen ones are duplicated, because one of them is understanding legislation and one of them is using oxygen. So, but that isn't evidenced in your portfolio. It's only evidenced in the actual program when you go onto Future Qual's website. So I've raised that as well. And Unit 7, which ones are duplicated from Unit 7? Can you remember off the top of your head?
Let me just grab my book and I'll tell you something about. It's about wound assessment and dressing, and it's just asking for the same thing twice. I cannot even find my bag right now.
I think there are a few points like that. I think there was a couple in maybe Unit 3, and I think it was something about managing an airway. And I think I'd done an OP on another job, and actually I could have used the same piece of evidence for both. I didn't realise.
Okay, I'll have a look at Unit 7 for the wounds and Unit 3 for the OP airways.
Yeah.
Just on the Unit 7 thing as well, what's on the printout that we're advised to print out and work from isn't replicated when you go to submit them. So just for Unit 7, when you print them out, it doesn't give you the list of 7 wounds that you need to actually reflect on. It's not until you submit them. And also, if you want them all done, then put them on bullet points, because that's what we've been told we need to evidence everything on. So when you first read it, it doesn't look like you need to evidence all of that because it's not bullet pointed.
Right.
Have a little bit more continuity.
Super. I'll put that on there.
Anything else? I don't know about other trucks, but we don't secure wheelchairs, and even if we get backed up by a bariatric truck, it's PTS that secure the wheelchair, so we're not trained to do that.
No, so I've asked about this, and carry chairs, you can use your carry chair evidence to do that. So if you've done your securing a carry chair in your Unit 13, you can just put that evidence in.
Oh, okay.
And upload that. All right.
Okay. Okay.
So use a carry chair instead of a wheelchair.
Okay. Cool.
Anything else? No? Well, if you think of anything, like when you're, finding it frustrating that you just had to do something or do something else, email me so I know, because it's your feedback that will make it easier for the next cohort and the next cohort and the next cohort. So if you think of anything, let me know. All right, guys, it's really useful.
Can I ask a question?
Of course you can.
About the helmet removal and stuff, does it have to be a write-up? Can I do a video?
So you can do a video. You can use any evidence type you like. You've obviously got to have 2 pieces. So things like consider a Q&A and a video. They're probably the 2 things I'd use.
Okay.
But yeah, use videos by all means as a demonstration.
Yeah. Might be easier.
Stuff for your radio checks, yeah?
No, it was for helmet removal.
Okay. Yeah,
but radio checks and MDT is absolutely fine also. Just don't forget with videos, you still have to include the what, the how, and the why. So you'll be showing me what, you'll be telling me how. Just make sure we know why.
Yeah.
All right.
Evidence.
Anything else? Any other questions in general?
Well, I'm still struggling with my getting my certificate. I've done the
hang on, Rayon, we'll talk about that in a minute.
Okay.
Hang on to the end of the phone call,
yeah,
and
okay.
then we'll chat about that as an individual. Anything else you guys want to know? No? Cool. Well, it was lovely to see you all. Lovely to meet you all. I wish you all the best in your career. I hope you go on to do amazing things and save many lives. Be heroes. And don't burn out. Look after your mental health every day of the week.
Thank you.
All right.
Thanks, Heidi.
No worries. Take care, guys.
See you later,
Enjoy.
guys.
Bye.
Thank you, Heidi. Bye.
No worries. Take care, Chloe. See you. Bye, Aaron. Right, Rayon, my lovely. Talk to me.
Right, so I don't know if you can see this. I've done this one.
Yeah,
but
so that's your LinkedIn one.
Yeah, right. I've uploaded this to turn it in, like what I said to do, and I've still haven't seen any sort of appearance on my certificate, so I don't know.
Okay, have you still got the email that I sent you with the step-by-step guide on how to access it?
Yeah, you sent me an email and to send what I've done, but I've got no. Do I need to share the whole portfolio with you to just look at it, or?
No, you just need to upload that certificate. So I've sent you I sent a link with how to upload it, how to find the blue certificate.
Yeah, but I've done that and it's not letting me do anything. It's just done anything.
Then in that case, you need to email a guy called Seb. I will forward you the email now of what you need to do. Because if that doesn't work, you'll need to email this guy because I won't have access to it to help you. So I will send you this. What's that? What's the actual thing called? Head Start, isn't it?
Head Start, yeah.
The only thing he asks is that you email from your student account, not your trust account. All right.
Okay. All right.
I've sent that to you now.
I'll just email him a copy of this certificate, and obviously I've done all the 7 modules, but
yeah, and just say you're struggling to access your certificate, the blue writing certificate.
Yeah, and obviously with your 375 hours, I've uploaded, but I've noticed you said that you need it signed by a clinician, so probably might need to copy those and get them signed and upload.
Yeah, it just needs to be signed by your team leader. So if you've done a GRS print off, have you done a GRS print off?
Yeah, I've done 3 print offs. So
yes, you just need an email. The easiest way to do it then is to get an email from your team leader to say how many of those hours have been clinical hours.
Okay, right. They should all be clinical hours.
But we don't know that. We don't know that you've not done all your shifts with an ECA. Do you see what I mean?
Oh, no.
So someone has to sign to say they were clinical hours.
Right. Okay. Yeah. All right.
Yes.
Cheers.
Cool. All right, Ryan. You know where I am, my lovely. So just because we've not got any tutorials left doesn't mean you can't.
Yeah. Any problems? I'll drop you an email. Okay.
Super. All right.
Is this the final tutorial for us then?
Yeah.
Well, nice, lovely. This one today was really good. Sorry about last one.
Good.
Yeah, a bit of a pickle with that one, but yeah, I'll let you know.
That's okay. Don't worry, my lovely.
Yeah.
All right.